Okay, so now it's time to switch gears completely and talk about atrophy, which is actually a type of growth adaptation. Growth adaptations are basically ways that cells can change themselves. So for atrophy, this means atrophy without growth. This means it's not growing, it's going to be shrinking, decreasing in size. So let's talk about this. Here we have a nice little sample layer of cells. Let's call them epithelial cells, and let's say, just because I love derm, they're skin cells, skin epithelial cells. So constructing an epithelium here, we have a layer here and maybe a basement membrane underneath it. We also have a nerve supply, to stimulate smooth muscle that's in blood vessels. And we all know what blood vessels transport, right? We just talked a great deal about it. I hope you remember. Red blood cells, and with those red blood cells, oxygen. Very good. So they'll also bring along nutrients like glucose and proteins and hormones as well. So there will be hormone stimulation to this tissue as well. So we need all these things to make for very, very happy cells. So we have a nice little smiling cyclops cell there. Okay, good. So if it gets all this, it can actually increase in number. What's that called, by the way? That's a type of growth adaptation. That is hyperplasia. What about just a cell increasing in size but not in number? That's hypertrophy or hypertrophy. Very good. Looks like he has little devil horns, little devious cell there. So, if any of these things are disrupted, though, then these cells will not be very happy. Oh, poor cell. Not happy one bit. And actually, if they're deprived of these things for very long, they may shrink in size through atrophy. And if they're continuing to be deprived, they may even completely fade away and actually program their cell death through, do you remember that? Apoptosis. Very good. So you can actually think of atrophy on a spectrum with apoptosis. It just depends on how long these cells, these poor little cells, are deprived of nutrients, nervous stimulation, and whatnot. And again, atrophy is a shrinking of cell size, and they can lose organelles, and basically they just use up enough energy to squeak by. So they're running on the bare minimum. Poor little cells. Okay, so now it's time for the very, very important topic of inflammation. Essentially, inflammation is just asking the question, how does your body respond to injury? So this slide will provide a nice little overview of inflammation. Alright, so here we have a blood vessel and a native cell, and there are several different things that can actually trigger inflammation. What do you think? Off the top of your head, what do you think would? How about trauma? Whoa! Like a knife wound like we see there, or burns, ouch. Or a common one too, could you think? Infection. Here's a nice little cute bacterium that we're going to want to take out. So how is our body going to combat this infection or whatever is triggering this inflammation? When this bacterium or trauma or burn is present, it's going to damage the native cells, release all kinds of cytokines that will stimulate in turn a certain type of cell. What type of cell do you think is stimulated in tissue? The mast cell, which contains a lot of granules, and it will release early products and late products. So the early product it will release is, can you think? Histamine. Histamine is a potent vasodilator and furthers the process of inflammation. What else would you think later on you think mast cells will synthesize? So after a couple hours or a little bit, they might make prostaglandins and leukotrienes, which are derived from what molecule? Arachidonic acid. So prostaglandins are synthesized by the enzyme, do you know? Cyclooxygenase. And leukotrienes are synthesized from the enzyme 5-lipoxygenase. Very good. Sometimes that's asked. So anyway, we have prostaglandins, leukotrienes, histamine. All this stuff is going to, as I said, vasodilate this blood vessel that we see here, increase vessel permeability so that fluid will leak out. It'll contract endothelial cells, bring them farther apart so that fluid's able to leak out into tissue. as well as inflammatory cells are able to leak out. So what do you think this would look like if inflammation is taking place in a person? Do you remember your cardinal signs of inflammation that are often in Latin? Well, here they are: calor, rubor, tumor, and functio laesia. Calor, what's that, if we can translate it? It's heat, right? Rubor, that's redness. Tumor, swelling. And functio laesia, loss of function. So the heat and the redness are going to be due to this vasodilation, and the tumor, like I said just a little bit ago, it will be due to all this fluid extravasating with the inflammatory cells into the tissue. And the loss of function because things that are swollen don't function very well. Here's a nice example we see here in an individual with orbital cellulitis. So you can see how red and probably hot and tender and swollen. This guy probably won't be able to blink very well. So I just said tender, so it's going to be painful. Isn't that another cardinal sign of inflammation? That's right, it is. And what is responsible for dolor or pain? Well, I put it right next to the prostaglandin because it's PGE2. Actually sensitizes nerve endings to pain. There's another thing too. Can you think of what it is that is responsible for pain? Bradykinin. Very good. Okay, continuing on here. So, we have prostaglandins, leukotrienes that are going to actually call in some inflammatory cells. What types of cells do you think will be beckoned to the site of inflammation? Well, how about our friends the neutrophils, and a little bit later on, macrophages. Specifically, do you know what calls in, is chemotactic to neutrophils and macrophages? How about LTB4? Very good. That calls in neutrophils and macrophages. We'll go over some more chemotactic signals in a little bit. Alright, so once the neutrophils and macrophages arrive, here they come to save the day. They can take out and digest this bacterium and save you from further injury. Alright, very good. So now let's talk about and compare acute and chronic inflammation. And essentially, the main difference between these two is just how long the inflammation has been present. Initially, acute inflammation occurs, and then after it resolves, or even if it persists, that will progress to chronic inflammation. So we're just going to compare right now, in general, the basic cells that are present in both of these. So let's start with acute inflammation first. So what cells will we expect here? Well, we just talked about neutrophils and probably something else too. Eosinophils, actually. What type of hypersensitivity do you see eosinophils present? Type 1. So with allergic reactions, that's a type of acute inflammation. We're also going to see antibodies. What type of antibody do you think is present? IgM. IgM is the immediate antibody synthesized by what types of cells? Plasma cells. So remember, that's a pentamer. 5 antibodies stuck onto 1 is an IgM antibody. And with IgM around, that's going to activate a certain inflammatory pathway that's called the complement cascade, C5a. C5a does what? Think of the A as an anaphylotoxin for vasodilating even further. C5a specifically will also call in more neutrophils too. Alright, very good. So comparing acute with chronic, what types of cells do you think we'll see in chronic inflammation? Macrophages. And macrophages are the key cell of chronic inflammation. They'll start coming in and replacing all the neutrophils. So we'll see macrophages, we'll see lymphocytes, more B cells and T cells. B cells turning into, what do they turn into? Plasma cells, and then they make, like we just said, antibodies. Except now they've had time to class switch, so they were making IgM, and now they're going to be making a different type of antibody. What's associated with chronic inflammation? IgG. Very good. And other types of cells and capillaries, granulation tissue will be present. The macrophages will be triggering the formation of this. Why the granulation tissue? To bring nutrients and other types of cells to come and repair and fix the broken, damaged tissue. So they'll bring in fibroblasts, these long spindle-shaped cells. Fibroblasts synthesize collagen, very good. Collagen, which will patch up the damaged tissue. Okay, and just in general, real quick, what types of chemical mediators would we see in acute inflammation? We already talked about histamine, prostaglandins, leukotrienes. What about with chronic inflammation? Cytokines, which ones do you think? Interleukin 1 and others as well, tumor necrosis factor alpha. Growth factors like fibroblast growth factor, platelet-derived growth factor. We'll talk about these in a little bit more detail later on. So to test your knowledge, we have a flash quiz. And this will help expand upon the knowledge that I already presented. So, the question is, what are the potential outcomes of acute and chronic inflammation? Boom. So for acute inflammation, what's a potential outcome? How about complete resolution? Now, I can't promise that you'll look as beautiful as this model here, but I can promise that your damaged tissue can completely resolve. It has the potential to. Well, what if your body can't completely resolve whatever is triggering the inflammation? Then it will just wall it off and keep attacking it with neutrophils, which are basically pus, and surround it with a fibrous capsule called an abscess, which we see here. What's this protruding from the skin? I'll give you a hint. It's too much granulation tissue. This is called proud flesh or a pyogenic granuloma. How about if someone has inflammation in their intestines and it actually bores a hole all the way through to the surface? What's that called? A fistula. That would not be fun. Bowel contents leaking out on your skin? No, no, no. What about this? What do you think the diagnosis is first? It looks like an abundance of scar tissue and collagen. So this is probably a keloid. And you know it's a keloid versus something else because it's going way past the borders of the initial injury. If it were confined to the borders of whatever was the initial injury, but there was still too much scar tissue, that would be called a hypertrophic scar. And here is just a normal scar formation when the injury is very deep and severe. This is a granuloma. And we're going to talk a lot about this in a couple more slides, but just know that this is a type of chronic inflammation. What about this? If someone has inflammation for a while, they run the risk of synthesizing a lot of inflammatory proteins that can actually build up and deposit in normal tissues of their body and cause problems. What type of disease is this? This is actually amyloidosis. And what type of stain is this? This is a Congo red stain. We call this apple green birefringence. And basically there's just a bunch of misfolded and accumulated inflammatory proteins depositing in looks like glomeruli in the kidney. We'll talk a little bit more about amyloidosis later on. So here's another random topic of cell injury, and this time we're going to be talking about injury to nerves. So here's a nerve, and just to refresh, what are the basic sections of a nerve? So the signal comes in from another cell and travels through this, which is the dendrite, very good, reaches this, which is the cell body, very good, and then travels along this section, which is the axon, and will travel to other cells. Very good. So, let's talk about what happens when the axon is injured. Whoa! Such as by a knife wound, like we see there. So, the way that the nerve will repair itself is called Wallerian degeneration or chromatolysins. So, what happens is there are three main changes that you need to know for your USMLE exams. The first is swelling of the cell body. The second is displacement of the nucleus. And the third, can you guess? What's going to need to happen if there's injury here? We're going to need to repair it, right? We're going to need an increase in protein and other substances to repair this damaged axon. So there will be an increase in what's called Nissl substance, or ribosomes, basically. That's another fancy word for ribosomes. And ribosomes, as we know, synthesize proteins. So all these newly synthesized proteins will help contribute to the repair of this damaged axon and repair this poor injured nerve cell. Okay, to change gears a little bit, let's talk about calcification. Did you know that your body can actually calcify? Wow, well it can. And there are two main ways that it can do this. The first we'll talk about is dystrophic calcification. So this is associated with sites of injury. So here's a sample cell membrane here, and let's say that this poor cell was injured or underwent necrosis or some form of injury, and pieces of the fatty acids were exposed from the cell membrane. So what charge are fatty acids? Negatively charged, right? So what could they complex with? I'll give you a hint. The answer's on the screen. They could complex with calcium, positively charged calcium ions, and this could form calcifications wherever there are sites of injury. And a common example that you might see on your board exams is in the aortic valve. This is commonly seen in elderly people because after years and years of pounding of high-pressured blood on this poor aortic valve, it can actually damage this and lead to dystrophic calcification. What do you think this murmur would sound like? Well, it would occur every time the heart pumps blood, so this would be a systolic murmur, and where do you think it would radiate to? The carotid arteries is the answer. Very good. Okay, so let's now talk about the next type of calcification, which is metastatic. When you think metastatic, you think of cancer, but it's not cancer. It's just implying that it's a systemic problem. So it's calcification occurring all over the body. So here's a nice example of someone's extremities, and we can see some calcifications here. So what's the underlying mechanism or reason for this? So it's probably too much of calcium in a person's body or too much of phosphate. One of those two things. So too much of calcium, what disease can we see this in? How about hyperparathyroidism? Very good.